Onc Live Insights is a video editorial program produced by Onc Live.
Once again, we are living a very exciting times for the treatment of chronic lymphocytic leukemia. At this point, we are very excited to see the development of a new BCL2 inhibitor, ABT-199, or already named as venetoclax, who really show a dramatic results as a single agent or in combination with Rituxan in relapsed refractory CLL. So these data are now being explored in a phase 2 or even in a phase 3 trial in the relapsed refractory setting or even in the front line, and really is offering a significant hope for patients who may already fail BCL inhibitors or they may require further therapies. Besides BCL2 inhibitors, of course, we have seen in the last year or two the development of multiple second generation BTK inhibitors and PI3K delta or PI3K gamma delta inhibitors, some of them with a better safety profile than the one already approved. And I really predict that we're going to see more and more data in the next year and the next meeting at ASH in Orlando. Even with Rituxan, obinutuzumab, as well as ofatumumab, there's still a space for drug companies to develop further monoclonal antibodies. We're talking about obinutuzumab. It's a new monoclonal antibody against CD20 who may have certain similar features between ofatumumab and obinutuzumab. We know that it has a better FC receptor binding effects, or like a high affinity FC receptor binding, who may confer a better antibody dependent cytotoxicity. And this has been recently published in a phase 1 trial in combination with ibrutinib, and once again we see significant benefits in terms of responses and PFS for the short follow-up that's been described until now.
So in terms of the new agents, there's a lot happening. I mean, we have more trials with new agents for relapse patients than we have patients to fill those trials, which is a problem. It's a challenge right now because people are going on commercial agents and they're doing so well that it's difficult to develop new drugs, at least right now. Now that may change with time as people are on the drugs longer. There are second generation BTK inhibitors that are in development. There are PI3 kinase gamma and delta inhibitors that are in development. As I mentioned, venetoclax, which is a BCL2 small molecule inhibitor, which is in development towards the end of its development cycle. I hope that we'll have that available soon as an approved drug for treatment. So there's small molecule inhibitors in development, and there are other treatment strategies that we're enthusiastic and excited about in development. There's the CAR T-cell strategy that's in development. We have clinical trials now where we're evaluating the checkpoint inhibitor monoclonal antibodies, PD-1 monoclonal antibody, PD-L1. We're looking at a CD137 monoclonal antibody, which potentially may enhance ADCC and NK cell activity. There's a KIR antibody that we're doing a clinical trial with, which also may enhance NK activity. So the checkpoint inhibitors and the immune modulating monoclonal antibodies, I think, is an area that hopefully we'll see positive data coming from. And then we've done a lot of work at Anderson over the years with lenalidomide. And lenalidomide has been challenged in its development for treatment with CLL. It has not gained approval by the FDA in any space for treatment with CLL. There's a randomized maintenance trial that will read out in the near future, so we may have some information with lenalidomide for maintenance, but so far it hasn't found its place in treatment for CLL, despite the fact that it has significant activity. I think there's value to lenalidomide. It does modulate the immune system. It works by a different mechanism than any of the other agents that we talked about. And there's a new molecule that's more potent than lenalidomide called CC122, which is currently initiating its development cycle in CLL. It's being evaluated as monotherapy as well as in combination with BTK inhibitor and checkpoint inhibitor monoclonal antibodies. So there's a lot happening in new drug development, new strategies. We didn't talk about cycling and sequencing and combinations of the small molecule inhibitors, but I think that's an area that we'll certainly see blossom in terms of trials and drug development as well. One of the other challenges in CLL is we've got great new agents to take care of patients, to treat the disease in patients with CLL. One area right now that we're expanding our work in is second cancers, because we know patients with CLL have a higher incidence of second cancers than the age-matched population, and their survival is shortened by those second cancers. They don't do as well with the second cancers. One hypothesis is that that happens because the immune system is dysfunctional, and that makes them at higher risk for the second cancers. And so we are working now with our colleagues in the stem cell transplant group to do trials in immune reconstitution, where we're expanding T cells and giving them back to patients. We're expanding NK cells and using those as, to infuse patients to treat their disease and to assess their immune reconstitution. And we're excited about drugs like lenalidomide and CC122, which is another immune modulating agent, given its potential to immune reconstitute patients, because their increased risk for infection and the increased risk for second cancers really highlights an area that has a need for therapeutic development. And if we can have a therapy that has efficacy in that space, I think we will be able to improve the outcomes for our patients with CLL, reducing the risk for infections and reducing the incidence and aggressiveness of second cancers.
Some of the new emerging agents in CLL include, probably first among them, venetoclax, which is in advanced clinical development. This drug was formerly known as ABT-199. It's a BCL2 specific inhibitor, and as such, it has obviated some of the problems of its predecessor, navitoclax, which used to cause significant thrombocytopenia that limited its dose escalation. Navitoclax, in contrast, has been pretty well tolerated. It's very potent, and its primary side effect is tumor lysis syndrome, which has had to be very carefully managed in the first 4 to 6 weeks of dosing. But following that, once a patient has escalated slowly up to their target dose, generally it's a pretty well tolerated drug, maybe a bit of neutropenia, but most people feel very well. And it actually has high efficacy clearing blood and bone marrow, and as well as lymph nodes, in contrast to the BCR inhibitors that are less potent initially in clearing bone marrow. The response rate's about 80% and complete remission rate about 20 to 25% in a population of patients who had had 4 prior therapies. So really a very potent drug. In the follow-up study in combination with rituximab, we're seeing about 40% complete remissions, 80% overall response, and about half of those responders are MRD negative. This drug is in registration trials and likely will hopefully be approved in 2016. There's much interest in combining it with ibrutinib in particular, and there's good data for potential synergy between those drugs in vitro. Duvelisib is a PI3 kinase delta inhibitor. It's a little bit different from the approved PI3 kinase delta inhibitor idelalisib because it also inhibits the gamma isoform, which could result in effects on T cells and myeloid cells, which could have beneficial effects on efficacy by affecting the microenvironment, but could also result in increased immune dysfunction. The data with duvelisib at present in CLL look quite encouraging. About 85% nodal response rate, 60% overall response rate. And this drug is in registration trials. A randomized trial compared to ofatumumab is ongoing. So CAR T cells have been investigated for a number of years in CLL. There was some initial excitement associated with the achievement of complete remissions in high cytogenetic risk patients with CLL, some of which have been durable. In the more recent updated data, the response rate in CLL patients has been down to around 40 to 45%, not all of which are complete remissions. This has raised the question of whether we need to better figure out which CLL patients are good candidates for CAR T cells or not. There is hope that this technology may lead to more durable remissions in CLL over time, but with the advent of the B-cell receptor pathway inhibitors, figuring out where to use CAR T cells is still a question. I think that they could have a role in consolidation for patients on BCR pathway inhibitors, particularly those with high-risk disease. If they end up resulting in durable remissions over longer follow-up, they could also potentially rival allotransplant as a consolidation for these higher-risk patients. But at present, the data are still relatively limited.
There is exciting times for the therapy for chronic lymphocytic leukemia, and of course there is also challenges by the community oncologists where they have to really incorporate several new modalities in their practices. This is the reason, and at this time, and it's time for really looking at large academic institution where we have much experience in order to really provide some guidance about the use of these certain drugs or the certain drug combination, so we can minimize as much as we can the toxicity that some of these drugs may have in our patients. However, I think with further time and more experience, these drugs, as is happening as we speak, are going to be widely used in the community oncology practices.